Well, hello and welcome to another edition of Health Solutions with Sean and Janet Needham, where Team Needham discusses everything healthcare. I am your host, and I am streaming live from the Moses Lake Professional Pharmacy Studio today, and I have the pleasure of having Matt Ohrt back on our show. He's been on, it's actually the third time he's been on, and he's been managing HR, human resources, and employment health for 20 plus years now, I believe, Matt, and I'll let him tell his story a little bit later. But he's over the last few years, he's really transitioned into, obviously trying to save his employers money and in a non-traditional manner. And he's had stories before where he saved millions of dollars for a medium-sized employer, actually. So, but still, there's people that are skeptical of any kind of alternative type of employer-based health insurance. And today he is going to discuss two stories. If we get a chance, we're going to at least discuss one of them, and we can have him on again if we don't get a chance to discuss the other one. And it's just going to comparing a traditional healthcare model to some alternatives that he has helped his employer transition into, and just you'll see the benefits of not only saving money, but also the patient getting better, the employee patient getting better care. So with that, Matt, go ahead and introduce yourself and tell us the story.
Yeah, thanks, Sean. Always great to be on the show with you. It's always, this stuff is fun for me. It doesn't feel like work, right? But right. I'm wired in a way. Maybe you'll find this weird. I'm not sure, but I had early in my career, I've always been an entrepreneurial spirit and worked for Toyota, and so learned a pretty cool problem-solving method. And so the part with me is that the bigger the problem that I come across, the more I get excited. So I don't know if that's weird or good, but it certainly helped me in my career in that, once you identify the problem, then if you have a good approach to solve it, things get pretty fun. And so imagine if I stumbled upon healthcare. There's just a few problems there might be. So there's a career worth of opportunity. And that's kind of, I did the work 23 years in HR. And I think when the COVID came, I kind of had my fill. I still love different pieces of HR, and I love people and I love leadership, but have taken on a new role with a great company called Team Cheryl Companies in Stevens Point, Wisconsin, relatively small town in the middle of Wisconsin. And but I've been leading a healthcare best practice group in central Wisconsin for 5 or 6 years. And my previous role was the VP of HR and medical services with a company called Merrill Steel. And we did some pretty cool things. We started off maybe not knowing nearly what I know now and what I've learned, but we saved about, I think still growing, but at the time of $5.5 million in about 5 years. And we increased a bunch of benefits. So it is not an RBP. It is not a reference-based pricing model, which has shown to work in some areas, but in our areas, the systems are pushing back pretty hard. So it's not that. In fact, I've entitled, I think, my strategy, maybe I'll come up with a little bit, adjusted name or a sub name, but I'm calling it Don't Feed the Monster. And so I've started a book with that title, and we'll talk about what that means.
Yeah, that's awesome. So I can tell over the past few months of just getting to know you that you're very passionate about this subject, and you're very active in it also. And I think that's what's important is that, some people, just like we were discussing right before the show, is that, people don't know what they don't know. You and I, we deal with this every day. So we take it for granted that, we know how to shop for healthcare and how to save ourselves or people money. But most people do not. So it's important to get out there and educate and empower people to take charge of their own health. And so thank you for doing this.
Yeah, it's kind of funny how things happen. I never would have predicted that I would be interested or passionate about healthcare. I never really was in my career, but so much so that it seemed to kind of come with me. So I think, in fact, the owners of Team Cheryl Companies, which were a retail company with about 63 stores and Subways and convenience stores and so forth, and tire centers, and they've actually approached me and asked me if I wanted to kind of lead a new division. And we haven't named it yet, but I already have calls coming in, and basically that would be a mission of helping other employers fix their health care. So I've got a roughly 5 or 6 or 7 kind of appointments already just by sharing that news. And I'm sure we can formalize our name, doesn't matter, right? But I do believe I have proven methods and strategies, so we can kind of talk about those. So one of the things, so I think the topic today is an interesting one, and it's comparing traditional, if you will, or at least what it's become today. Traditional actually wasn't so bad. Dr. House calls, if you want to go way back,
right?
What the systems have developed, what they've turned into, right? They've started out as nonprofits. All but 3 in Wisconsin are nonprofits, and they start out mission oriented, and then their aim to serve, and it's not about money, it's about healthcare, but healthcare has become wealth care, and the care part might be missing. And so you have a lot of nurses, a lot of doctors, and a lot of others in the healthcare system that are extremely frustrated. These things are coming from the top, and they went kind of Animal Farm, as I call it. If you've ever read that humorous book by George Orwell. And basically animals take over the farm, and they start out good, and it's a quick read and a good read, but essentially most things start out with good missions, and but they can go awry pretty fast just because of our human nature. Greed comes in and so forth. And so our hospital systems have been hijacked by hospital administrators who are making millions, and hospitals are now making tens or hundreds of millions, and they're no longer really serving the community as they originally set out to do, and while not paying taxes to the community at the same time. So we kind of have an emergency situation, in my opinion, a dire situation that employers are the ones, and we need to step up and help fix it. We're the ones paying for it.
Yeah, yes, for sure. So tell us, you have a story of a knee replacement, I believe, or some kind of knee surgery in the traditional system versus some alternative methods that you've promoted. And so tell us that story.
Yeah. So what I'd like to do is, and I've worked with several MDs on this. So this is a story that I think probably happens every day in America. But this is not Matt's opinion. This is coming straight from MDs. And what we're doing is we're setting side by side. We're setting whatever we want. I've labeled it traditional, although I just want to be careful, because traditional way back actually was really good. But currently we call it current hospital system healthcare, and what it's come to be today. And then an independent side, a side that would be part of my strategy of don't feed the monster, right? So often we feed the monster that's trying to eat us, and I just don't think that's very wise, right? So we have to realize the motives and the methods of the monster, and that's kind of, the monster refers to the big healthcare system overall. It's several entities, so I don't mean to put others down, but others are using words like cartel and swindler and all sorts of things, and I think we have to be honest about where we are today. So we have a situation here where a person ends up needing a knee replacement surgery. And so what I'd like to do is just compare and contrast the two ways going side by side. So if we look at the current system side, the traditional side, if you will, the hospital systems today, we call and make an appointment, and in this case, we get the appointment 4 weeks later with primary care, which isn't uncommon, right? So now I've got a swollen knee, and I've got pain in my joint, and now I've got to wait 4 weeks for an appointment. So already I'm from the gates, I'm in a bad place because I'm in pain and possibly getting worse when there might have been some early intervention. So I get a 15-minute appointment, and right, and that's pretty common. And there are exceptions to that. I realize that there are, but I would say that's the norm. And if you hear from MDs, it's not even actually 15 minutes because there are vitals and there are charts in there. So, in fact, if I may, I'm just going to read from Daniel Paul, MD, just a recent post as this podcast was coming up. I'm printing a couple of things here that I'd like to share with you. Here's Daniel's opinion, and he's an MD. I don't care how good of a doctor you think you are. If you only have 15 minutes allotted to each patient, with only half of that time for the actual visit, the rest is for charting, you are doing somewhat of a disservice to your patients and also to yourself. 7-minute appointments normally allow for one problem to be discussed with almost no time for patient education or informed shared decision-making. It's more of the doctor interrupting, diagnosing, explaining for 30 seconds, and then giving the treatment plan. While this might meet the standard of care, the quality is actually pretty low. As there is no relationship formed, it is really a transactional undertaking. A transactional undertaking is great when you are buying coffee, but it is inappropriate for the doctor-patient relationship where there are complex educational, social, and economic issues at play. Now, if a physician decides to go rogue and spend the appropriate amount of time to do a good job, they will likely be pushed out or fired. The clinical managers won't like it, the hospital system doesn't like it, and there's no way to maintain your insurance-based practice with that low of a volume. So I think it was just kind of a neat story from an actual practicing MD who knows this stuff. And it really emphasizes, right, let's be careful, because these problems today are often not caused by the doctors or nurses. They're put into this system and they're very unhappy because they're not able to do healthcare. They're doing more wealth care. So, all right, so we have a 15-minute appointment. We have, in this case, I'm comparing two plans as well, because we have a typical benefit plan with a $6,000 deductible and a $10,000 max out of pocket on this side. So $220, that may be understated, but I'll stay conservative in the example. $220 for the primary care visit, some medication, and then 10 PT visits. Interestingly, the paths here are very similar on each side. The cost and quality are very different. Now, in the diabetes example, which we probably won't get to today, the paths are very different and the quality of care is very different. But here, it's not all that different. So then we do the 10 PT visits, and now that costs $150. So that's another $1,500 out of pocket. And then we have an ortho consult. It looks like, right, the PT wasn't able to help, which is a good try. But we have an ortho consult. That's cost $350 to the patient. And then we have an MRI where we want to see what's going on. So now we're talking a median cost. This is conservative. I would say it's higher in our area, where we're paying 400 to 600% of Medicare. And in this case, $4,400 to the patient for an MRI. And then this person starts to meet their deductible, right? A follow-up ortho cost, which is more visit, which is more cost, $350. And then we have the surgery performed, which in our area, even a somewhat conservative price from the system, is $68,000 for that surgery. So, and then we have some PT rehab, which is another 150 times 10, 1,500. And we end up with a situation in which the $10,000 max out of pocket was paid by the patient. And we end up with a total plan cost of $66,790. So a total cost of almost $77,000. Okay. So kind of interestingly, we juxtapose. You like that word? I learned that word many years ago.
Repeat that?
I don't get to use it very often. We juxtapose. We set these things side by side. I sound like Keith Smith now, pulling out big words. So as we compare that with, right, sometimes the big buildings, the big monumental buildings are viewed, I think this is my experience, just as when you implement an on-site or a near-site, sometimes, I think we can change this through education, but they're viewed as somehow better. And what we have to realize is let's break this down just like we're doing today. But often it's not better. In fact, it's worse. And it's certainly more costly. So, and by the way, where do all these doctors come from to start these independent practices? They come from the hospitals.
Right. Right.
And they're maybe the ones that have just had enough, and they have the initiative and the drive and the know-how to say, I can't do this anymore. That's not why I went into healthcare. So kudos to them. It's happening all over. I think there's a movement starting in America. Yeah. So we look at the independent side. Now we call to the doctor. Now we get an appointment the next day. I think that's very reasonable. I hear it over and over and over again.
All the time.
Yeah. So that's very reasonable. If someone ever feels that I'm exaggerating on a story, let me know, because I don't feel I am. I've ran this by several MDs who have worked both in the system and the independent. We get a 40-minute appointment because that's what it actually should take. So there's plenty of time to educate it and discuss. And in this case, by the way, the plan is designed that if I go to preferred providers, which ones that share the price, ones that have good quality, and ones that work with us and are in it for the real reasons of healthcare, care is still in that word, then in our case, there's zero copay to the associate or their family members. So in this case, this is covered by the company. It's probably around, you could do PM or whatever, but it's probably around $150 visit in actual cost, but it's paid 100% by the company. Similar medication for swelling and for pain, just to get through this. 10 physical therapy sessions, which under our plan, we have a small network of transparent and physical therapists. So that would be, again, no copay to the person. So all they've paid is $57 so far for some medication. So you go through the 10 physical, same on the other side, you go through the 10 physical therapy. We're able to prevent it. Many times we are, by the way, but in this case, the surgery is needed. So we talked to the person about options. Now we've got options in western Wisconsin, southern Wisconsin. We have to get out of our little area because the system has that controlled and has the independence controlled within 30 to 60 minutes. So we have to drive a little further. So they've monopolized the area pretty effectively, but that doesn't stop us. So we can go to Green Bay. We can go to Appleton in our case, which is eastern Wisconsin, or we can go to Wellbridge, our friends down in Indiana who are just getting started, or we can go to Oklahoma. So we're going to put those options, we call our plan options, and we're going to put that in front of the associate or the family member, and we're going to say, what do you like? There's even a small incentive. Now we mostly have the zero copay. That's the incentive, but we have incentives if you want to go to Oklahoma because they're even that much less. So then once we find out where the person wants to go, then we would hold their hand through the whole way, usually with a PT in this case, because it's movement related, but they'd hold their hand and they do a virtual consult with the actual surgeon of where they want to go. We don't want to waste the surgeon's time. So we ask, where do you want to go first? And in this case, then we make sure that the surgeon agrees there's surgery and what kind and can answer the questions. The person feels comfortable. And then we would schedule the surgery. In this case, let's say it was in Green Bay. That's the cost I have down here. This surgery, by the way, in Oklahoma is $15,500. But this surgery in Green Bay with the right kind of provider is $23,000. So pretty close. And Oklahoma is all cash based, which is what I would recommend for self-insured employers, right?
You know what? Just let me back up on that, sure. Matt. When you're comparing the Surgery Center of Oklahoma to Green Bay, 15,000 versus 23,000. Mm-hmm. Only in healthcare would we say that's pretty close. Right. Because we were going to say compared to Green Bay, or Surgery Center of Oklahoma, I was going to guess, because usually it's about 8-1. So I was going to guess Green Bay was going to be 100,000. So, you know, if you're comparing healthcare to cars, if you were buying a car for $23,000 and you could get the same car for $8,000 a few hundred miles away, that's not pretty close.
We wouldn't say pretty close, would we?
No. That's how screwed up our healthcare system is, right?
It is. I mean, you make a great point, because we're usually, what I tell the owners, we're talking in $100,000 increments usually when we're talking healthcare, just because everything's inflated so much. Right. And I had asked the CEO, by the way, of this one in Green Bay, a great surgery center. They do surgeries for the Packers, which we didn't get a Super Bowl and still striving here.
I know, and I was rooting for Aaron Rodgers this year.
Right. Yeah, that was a bad ending. So, but this surgery center is top notch. They've been open a long time. I think close to 100 years, something like that. But they're one of the top ones in the state. And so that surgery there. Now I asked her one time. I said, "Why?" Just curious. I mean, don't get me wrong. You're transparent and you're just what we want. Why is yours 23 and why is Oklahoma's 15,500? And she said, "Matt, I employ 9 more people, because we still deal with the insurance side." So they're pretty competitive overall. And Oklahoma is all cash based. Now you can set that up with your employer through a self-insured plan. So, right, it's not just pure cash. It can work through that method, but that's part of the reason. And Oklahoma is really efficient. They're really good at this, and they have some of the best surgeons. So, but in this case, we'll say 23,000, right? Not pretty close, but 23,000. But still much better than 60, 70, or 80,000 at the two systems in our area.
For sure.
So in this case, how does it work out? Well, we've kind of set the two side by side. In this case, we've got, find my summary here. We've got $15 paid by the patient. So I had said 57, that was an error. That's how much the medication actually cost, but it was a $15 copay. So the patient paid $15 and the plan paid $26,837. And one of the things I hadn't pointed out, right, in this MRI, by the way, this MRI that was $0 to the patient, that was $600 to the company, is often the same truck. Right? Same truck, same driver, same tech. So let's make one easy little example, right, is we talk about quality. So it depends on where the truck is parked and where the truck is plugged in to whether it's $600 or $4,400 in this example, often $5,000 plus. So if we think we're getting less care, in this case, we've also had that longer, from a quality measure, we've had that longer appointment with the primary care. So there's being a relationship developed, just like old school healthcare, right? Where the doctor wasn't limited and actually came to your house, and there's a relationship. So if I've ever got a future issue, one, I can afford it because it's zero copay. So I'm not putting off my healthcare. But I develop a relationship, and that person, in this case, our DPCs, our independent clinics, are available by text, are available by phone, are available by email. So if I have a quick question, or I just need a renewal of my prescription or whatever it may be, I'm not bothering the doctor. This is what they're enjoying. This is what they're got the reason they got into healthcare. And interestingly, if we look at the other side, there's lots of dynamics and lots of ways to analyze this. But think about it, so healthcare plans, probably for the last 20 to 25 years, is when this downhill slide really started to happen, and when the systems really started, the prices just shot up year after year after year. But if you have a $6,000 deductible, now this is after your premium, by the way, which is probably pretty big. So a premium or paycheck deduction or contribution is before I even think about healthcare. So let's not forget that part. So premiums are really important. But if I don't even use healthcare, in some cases I've seen outrageous numbers, $600 a month, $800 a month, $1,000 plus a month.
For sure.
My friend Carl Schuessler made a post recently in some of the premiums in Texas, and I responded. I said, "Those are insane." And they were like $1,500 or more a month. This is
right. Yeah. I had a friend who just yesterday, she posted, she's a pharmacist, and she posted, when your healthcare premiums are more than your house payment, that's a problem.
Right.
I mean, think about that. I mean, we would have never, ever thought that was going to happen.
In many cases, they are. I mean, there's a stat by 2030, for a family of 4, it's expected that the healthcare premium will be 52% of a patient's income. So that's above the house payment, because usually when you look at the house mortgages, they're like, or anything over 40, they won't approve you.
Right. And even 40 is really, really high. I mean,
right. And so we're seeing, as I testified in front of the Senate a few weeks ago in Wisconsin, in Madison, in the big Capitol building, and I was telling them, I said, I think we're in kind of an emergency state. I think, or we're approaching it very fast. When one of the senators spoke up, they're starting to get educated. One senator said, "I've recently read Marty Macary's The Price We Pay book.
Mm-hmm.
Been listening to it on my commute." And another senator said, "I went through a divorce years ago, and I needed a surgery, and I was hurting for money, and I needed an affordable." I think it was before he was a senator, maybe even, but I needed a fair price surgery, and I actually went to Oklahoma. I searched around, and some gave me prices like weeks later, which is pretty good achievement, actually. But many wouldn't.
Right? At least they got a price.
I don't give prices when I call. Many wouldn't give me the price, and I ended up going to Oklahoma, and I thought, boy, here's a Wisconsin senator having to go 700 miles, actually further. It's closer to 1,000 miles to get a fair price surgery. So what's happening here, right? So just to finish my thought, so on the $6,000 deductible, what are after the premium, which I touched on, right? What are we likely to do as healthcare consumers, right? So what are we likely to do? I can tell you one thing: if I'm paying a large premium already, and then I have to pay the first $6,000, I'm probably avoiding healthcare. Don't you think that's natural?
Yeah, right.
So therefore, I'm not getting. I can't.
Let's back up, Matt.
Yeah.
That's really what the insurance company wants you to do.
It's less cost, isn't it? For
yeah,
that?
They don't want to pay for anything. They really don't. I mean, so they've got this system figured out and rigged for their betterment, not the patient's betterment. So sorry to interrupt, but I just wanted to interject that.
No, love it. Yeah, love it. So I think these high deductibles, and that's what's happened over the last 20 years, is that we're potentially avoiding care. And so what happens with that one? Our quality of life goes down, right? It's like, well, my knee hurts, but not bad enough to, lose my vacation and my boat or something I wanted to buy or whatever, or I can't even afford it. I'm meeting with someone in a couple of weeks. I was giving a presentation to a lean group, and I was talking about the interesting comparisons between lean and the way I practice healthcare, right? It's taking out the waste. It's taking out the steps that don't add value. She said, Matt, I don't know if I've heard a story worse than this. I've heard of lots of bankruptcies, but she said I had to take $72,000 out of my retirement just to pay my medical bills. I don't know what kind of insurance, or maybe she didn't, but $72,000 out of her retirement. And I don't know about you, that would probably eat up my retirement. I always say I'm going to retire early at 90. I got 6 kids and we're foster parents, and right. And so I go home to a circus, come to work to rest. No. But 72,000 out of your retirement, that's most people, that'd be easy bankruptcy, right? There's a stat that says 2/3 of bankruptcies in America are related to healthcare, and then 3 out of 4 of those had health insurance.
Exactly. That's one
So,
thing that people, actually, Dr. Keith Smith, we talked about Surgery Center of Oklahoma a lot. Dr. Keith Smith's the one that I saw him comment on a post about, medical bankruptcies. And he reminded people that 50% of those, or plus 50% of those, have health insurance already. So obviously the traditional health and system arena is not working to protect people from medical bankruptcies. It is not working. I mean, in fact, you could argue that that's why it's not working, is because of the health insurance companies. So it's very compelling to me to see that most of the bankruptcies were with people that had insurance already. So why should we believe that system works?
Right. I mean, I'm a capitalist. I believe in hard work, and I believe in free market and those kinds of things. But if you look at the number of people that the hospital systems are suing, right? And I get it. They can't give away I get that, right? They have to still. But when you're having tens of millions in the bank and hundreds of millions in the bank, and you're buying farmland, and you're giving the top staff 20+% increases and making millions. I don't think that's sustainable, and it certainly doesn't look like serving to me. And years ago we looked, and there was one system that was suing. So these are intentional, by the way. These aren't put you on a plan or anything. Suing 400 people in a 90-day period. That was just one system. So the thing about bankruptcies isn't accidental. They're assertively causing it.
Well, and I think the system has created hospitals to just be monsters. And when you talk about don't feed the monsters, I think hospitals are definitely a monster. Private, public, profit, nonprofit, it doesn't matter. They're all, they all seem to be in it for just the dollars only. It's not about charity. On the credit issue or the suing issue, I heard of one hospital system. I did not verify this myself. I got it from a very good source. He said that there was one hospital, I believe in Tennessee, that they saw such an opportunity to sue people in collections that they bought a collection company. So they own a collection company now. I mean,
be more efficient when they sue. Yeah.
Yeah. I mean, talk about a conflict of interest. And if that doesn't show you how hospitals really don't care about anything besides the dollars, I don't know what would.
Well, there would have been more money in that for them. Normally you don't see efficiency steps. I'm not sure they know what that word means. One of the things, I've been networking and meeting lots of great people. I talked with a Dr. Bill Hennessy, and he is showing me statistics about how ER is their number one moneymaker over even everything else. It's 5 times plus the rate. I saw a post from a doctor, so James Tinley, but think about this thing. We need healthcare, right? It's not that I'm going out and I'm buying some Cadillac. I need healthcare. Now I have, if I'm not in what the world we can create, right? We can create it. We can help others create it. This independent system that works like that. It gives us fair prices and works like we'd want it to. But it becomes like a ransom. So that if I'm in this traditional, which are most 90% of employers, it's like a ransom for my health. So if I'm in ER, I might not even be conscious. So here was a post by Dr. James Tinley. You charge, very brief, you charge $15 for a $3 gallon of gasoline during a hurricane, you go to jail. We have like 27 convenience stores. We sell gasoline in our Team Cheryl company, right? But you go to jail if you manipulate an emergency and profit from it, right? You take advantage of the person who's incapacitated or weak. I can't imagine a more dire situation. But you go to jail, but you charge $3,000 for 3,000 is really low. How about 5? You charge $5,000 for a $500 MRI, and you take legislators out to dinner and make billions. So here's a case, not to get I guess too candid, if there's such a thing, but here's a case where And why is my strategy don't feed the monster? Because I can't fight the monster. The monster will eat anybody they fight, because they're overpricing. They're really, really wealthy. And so the extra money they're getting from really bad ways, from bankrupting communities, now they're using in the lobby. They're using in the lobby arena, and they're using it to have laws. When I testified in front of the state Senate, it was for a bill they called white bagging, which meant that drugs that need clinical administration or infusion, they wanted to, basically they're saying we want a monopoly on that. There's been a few cases, they even brought in cancer patients. I felt horrible. I care for those people, but they brought in cancer patients. And so basically I think the exception where the drug didn't arrive on time and there was some small hangup, and saying because of this, we want to buy those drugs directly, and we want a law that says only hospital systems can, say, infuse those drugs. And we think about this. So if we see them as this nonprofit, benevolent, organization, then that would be like, yeah, they really care. They really care. And so I just don't think that's the case, because it would be like the two largest auto mechanic shops in town, and say there's 20, the two largest saying, we're just not getting some things on time. So the wrecker services, we want a law that says they can only take the cars to us.
Yeah.
Never mind the others. But we want to create a monopoly on this. I have very little confidence that they problem solve, or that there wouldn't be minor issues, of drug delivery. Give me a break. But they're actually still trying, and they're even trying it through law. So I think fellow Americans, we need to wake up to what's happening here with the so-called nonprofit healthcare systems. And employers, this is part of maybe what will be the rest of my career for 15 years, is to help employers fix this. And we have pretty reliable ways, but if you don't take the initiative, you're going to feel this pain, and it's only going to get worse. So I think it's up to us to do it.
Yeah, and I think some people just think, talking about the monster, they realize the monster is so big they just can't fight it. So what do? They just get eaten by the monster. But like a good doctor one time said, he's a DPC doctor. He said in order to fix the system, he had to get out of the system.
Right.
And that's essentially what you're doing, with employer, the way you have employer relationships with these healthcare companies is you're not fighting the system. You're just, you're circumventing it because you have to. And I love the gasoline analogy. That is a great one. And Dr. Tinsley's been on our podcast. Mm-hmm. And what happens in healthcare, it's amazing. It's legal, because it would be illegal in any other industry. The cartels that have been created between health insurance companies and hospitals, it's literally a cartel, and it would be illegal. They use mob tactics for all kinds of different things, whether it be to control physicians or whether it be to control consumers of healthcare. It would be illegal in other industries.
Yeah, it's amazing. And I think there is a movement started. I mean, we have, and more awareness. I mean, things like this, the more we can educate, especially those in legislature, to be aware of these things and not be fooled. This white bagging bill in Wisconsin, they had something like 70 Congress people supporting it. And so now we've gathered about close to 100 employers, and we're pushing back and saying, if we don't start stepping up and educating, we're going to be in real trouble. I mean, we own tire centers. And so, for instance, in Wisconsin, there's what's called consumer, these are almost humorous and sad at the same time, consumer protection laws. If I take my car to a mechanic, which we do all sorts of mechanic type work, tires, and we'll replace engines or whatever. But if I take my car to a mechanic, then I am owed many things. I'm owed an estimate, a written estimate before I have the service. And if I want the old parts back, you ever seen that trick in automotive, right? Yep. Yeah, we replaced your alternator. You don't even know what an alternator is. So we replaced your alternator. No, I want the old part back. So I want to prove that. And mechanics shops can get in a lot of trouble for not following those basic consumer protection laws. We even have a federal funeral law that protects makes the funeral home have to give transparent prices and different things. And right, so the joke is, here we have a case where our cars are better protected, or at least when we're getting our cars repaired, and the the dead are actually better protected than those live people seeking healthcare.
Wow.
So something needs to give, doesn't it?
Yeah. So back on your knee surgery story. So what was the total? I don't know if we finished it. I know we're both so passionate about this subject
Right.
that we get distracted. And so, what was the total price saved, and in the traditional versus the traditional system?
Yeah. So from the patient perspective, and just to kind of reiterate that summary, right? So the quality was better. We've talked about that. We
Yep.
talked about the time of care and the relationship developed and texting and phoning and so forth. But in the current hospital system method or process, that the patient met their max out of pocket, so they paid $10,000, and then the plan in so-called insurance. Remember, if you're self-insured, folks, you're writing a check for this minus stop loss, but $66,790. So that's a total cost of $76,790 on the hospital system side. We're both wrote big checks, right? The patient and the plan and the employer. As we put that side by side, then we see on the independent plan, on the preferred providers, we have a patient cost of $15. That was a copay for the medication. And we have a total plan cost of $26,837. So about close to a little less, 1/3 of the plan cost was 1/3 less, and the patient cost $15 opposed to $10,000. 10,000 can put a lot of families to have to file bankruptcy, right? I mean, not too many families have that kind of money saved up, and if they don't let you, they're supposed to in many cases, but if they don't let you on a payment plan, and you start getting collection letters, which are extremely common, it puts families in a very bad place. So we look for win-wins, right, Sean? I'm sure you, right? So win-win situations. And if there's
that was literally $50,000.
Just
right?
in one example. Yeah, just
That was a knee replacement.
right.
Wow.
Yeah, and so we start doing this across the board. We take the top 10. So we're talking about everything from mammograms and colonoscopies and knee surgeries and hip replacements and cartilage tears. And you can imagine how we actually save money. There's a saying, I'm not sure who coined it, but in order to pay less for healthcare, you have to pay less for healthcare. So here we credit to whoever coined it, but here's a case where you're actually right. You have to look at what you're paying. One, you have to know what you're paying before you get the bill, and then find the smart options. So,
well, and I mean, and it wasn't that difficult to save $50,000. I mean, as long as you know how to navigate the system. And I think that's one thing that we need to do, Matt, is just, teach people how to navigate the system. And I will tell you that, as a healthcare professional myself and working with a lot of doctors that are obviously healthcare professionals, we know how to navigate the system. And one of the hardest parts is to, teach employers that, that this is what you're doing. Premiums going up, what, Matt, 20% a year sometimes?
I had one call me and they said they went up 100% 1 year a few years ago. That's a story to remember. But yeah, the average is 6, 7, 8, 9, something like that, depending on the year.
Yeah, and it's not sustainable. I mean, and so they have to find an alternative method, and that's what I appreciate about you educating us on, Matt, is that you're tried and true. You've done this with big employers, and it seems like the bigger the employer, the harder it is to educate them on this. When in reality, it should be easier because a small self-insured employer, how many total knee replacements do they have that they could save 50,000 on? One every 10 years? I mean, I don't know. Obviously it depends.
Probably more often even. Yeah.
Yeah, but think about a big employer with like thousands and thousands or hundreds of thousands of employers, of employees. They could save millions and millions
Tens of millions. Yeah.
Tens of millions.
And we're talking about, right, if we can get employers engaged here, we're developing a method that will help DPCs be able to find those options. So if anyone has any and needs any help there, we have some good ways to do that. But we're talking about an employer. So employers are the gap here. I think I'm going to be speaking at the Free Market Medical Conference again in Texas in May.
In May, I love it. I just saw the date come out last week. I'm super excited. I'll see you there.
Yeah, and it's a blast. Great people who care about communities and who are helping. Right, we're trying to come together and help. But we're talking about, and the employers, I think we'll see, but the employers are a big focus because many providers and doctors and nurses are breaking out, and we have all these resources. But if employers, especially self-insured employers, don't take the step on what is typically their second or third highest cost, right? So your second or third highest cost has been off your radar for the last 20 or 25 years, and we can just through good methods that actually increase benefits, we can remove 10 to 40% of the cost of that cost. That's big dollars. How often do employers scrape for 1% and they say you need 3 quotes on that vacuum, or don't buy those paper clips or pens. Office supplies are killing us. Have you ever heard that? Office supplies. Are you kidding me? So we write these $100,000 checks for healthcare that we could have got for 20 grand, and it's just off the radar. So CEOs, CFOs, HR leaders, a lot of times people don't want to be first, they'll be second. But I would say in this case, I'll argue it is second or third, because I can tell you stories. We've frozen premiums. We froze them at Merrill Steel. I think this went on their 6th year in a row. They tell me that never happens. Here at Team Cheryl, I think we're on our 5th. So freezing premiums, and in many cases, we've lowered them.
Well, I think, insurance companies have been raising premiums and decreasing services for years because they've gotten away with it. And they did it because they can. Or why do hospitals increase prices all the time? Right. Or have non-transparent pricing or super inflated pricing? Because they can. We haven't called them out yet. Yeah. And I mean, we have to a smaller extent, but that's why we need to make this a big movement. Because, I mean, just like you're saying, you were given the example in Green Bay where there was one of the systems that was fairly reasonable, 23,000, but there were some of the systems, a couple of systems that were, 60 to 70,000 for the surgery or whatever. They do it because they can. But and so obviously a majority, a huge majority of that system is a payer mix from some kind of healthcare insurance company. But if people start going elsewhere, they have to change their price if they want to stay in business, period.
Right. And just to clarify, Sean, that wasn't a hospital system. That was a large surgery center with about, I think, 12 locations, but that was there. So it wasn't a system. There aren't too many hospital systems. There's one in Nebraska, I guess it's in the price we pay, I think, that's actually making money on the 100% of Medicare. And, there are a few very rare scattered hospital systems, but in almost all cases, we're going to independent providers. And the systems have gotten so big and bulky that they're right.
Right. And I should, thank you for clarifying that, because I try to, I call it, even though, there's small corporations, but it's the big healthcare corporations that have, really taken advantage of the traditional healthcare system. So the big, super big, surgery center clinics and things like that, they're guilty of overinflating prices too.
For sure. It depends on who you're talking with, right? There are some that are free market minded and some that aren't. But I'll tell you one thing in this book that I'm writing, and Don't Feed the Monsters. What's interesting is I went to a system a few years ago, and I said, yeah, we're going to be sending people to Oklahoma, but we would like you to bundle, right? That's one language. They don't want to talk. They put their numbers online and they're all scattered and can't read them and can't interpret them, but we'd like you to bundle. Well, they thought about it a while, and a week or so I get this long email that says we're unable to bundle. So, not unwilling. And so later conversations, I said, let me clarify. I mean, this is in this case, the surgeon cost, the anesthesiologist cost, and the facility cost. So we all can add 3 numbers, right? But they were unable. So, but 2 or 3 years then I revisited this conversation with them, and I said, yeah, this is working out well. We've sent 3 hip replacements from here to Oklahoma, and now we've got local ones as well. And we started out with Oklahoma. I had talked to Keith, and he's like, we can start this afternoon. I mean, that's how easy their contract is.
I know, it's so cool.
Our prices are online. They're the model. They're the model for the country. So providers, if you want a model, talk to Keith,
Yeah.
look at SEO. But you know what was interesting of their response when I said, we're sending a fair amount of surgeries there. You know what they said? She goes, we'll bundle. And I thought, well, isn't that funny? Because you were unable to, but I didn't say all this, right? But it's going through Matt's head, you were unable to before. And by the way, I said, great. I'm not here to criticize you. Great. Good for you, because that's exactly what we want you to do. We're not here to fight. We're not here to fight. But I think this don't feed the monster, then what happens? They lose revenue. What do they care about most? Wealth care, revenue.
Right.
And so that gets their attention, and then they change their ways. So their prices will have to be, if they lose enough revenue, their prices will have to become transparent. They'll have to work with you like a true seller of healthcare services should. And that's our strategy of making this all good. We're not here to fight. We don't wish anyone ill. But when you have a bad player, you have to deal with them somehow. So that's how we're doing it.
Well, and it's like any other industry. We just have to call them out on pricing, call them out on service, call them out on quality. It's like any other industry. And traditionally, those big systems just have not been called out. They haven't had to compete. And you brought up a good example. When they're made to compete because they are losing business, all of a sudden they can find a way to do it. Oh, sure. Yeah, we can do bundle pricing.
It's amazing. It's not that hard.
Right. It's like, whoa.
Right. Yeah, I always found that humorous. It's funny, you don't think you're on the phone and you don't think you're going to have a memorable moment, and then they happen, and it's like, oh, that's a good story. I'm going to remember that one.
Right. So tell us a little bit about your book. When do you expect it to come out?
Yeah. Well, when I go home, I only have 6. We got 7 total, but 6 kids in the house, and we're foster parents. So we bring in babies that have been on drugs or the mother did drugs and so forth. So
good for you.
That takes a little time, but I would hope within the next year that I could get that out there, get it finished. It is started. It's got a great start. And so I'm putting a little time into it whenever I can. I'll go down to the office for an hour or two and keep adding to it. But yeah, really excited about that. And hopefully that can be, a guide for employers to learn some of these techniques.
Yeah, I'm super excited to have it come out because I'll refer to it quite often. I'm super excited to read it. And, I think I've read part of it, right? I think you've sent me the introduction, I believe.
I've got bits and pieces. Yeah. And I can write. I got some friends that actually write really well. I might pull them in, but English was always my goodest subject in school. So I think I can write pretty well.
Yeah.
By the way, if you're wondering. So.
Well, I will tell you, from writing a book myself, it's a big undertaking. And when I went down to put my stuff on paper and actually put it into the book, I'm like, oh man, I need somebody to help me because I'm a pharmacist, not a writer. I can tell that right now. And I had all these great ideas, but I just couldn't put them down in paper.
Yeah, it's kind of a skill set, isn't it?
It is, for sure.
Say it pretty well, but then it's another thing to kind of write it. So hopefully we'll make it fun and interesting and well written. So it's both, great information, but also fun to read too.
I'm super excited. Well, we're going to wind this podcast up today on that note, and we want to have you on again because we want you to tell the story of diabetes. A knee surgery is a kind of an elective surgery, so to speak. So some people might argue, well, what about chronic disease? How can you save money on chronic disease? Because diabetes is expensive or whatever. So I'm super excited to hear that story. So we'll have to have you back on to share that story, and and share the progress of your book.
Yeah, that'd be great. Yeah, the diabetes example is quite different. It's got different dynamics in it, and so I think it is valuable to hear how that compared and contrasted, and we can definitely do that. So let me know.
Yeah. So Matt, if anybody has any questions on this subject, what's the best way to get a hold of you?
Yeah, probably by email. So it's matthohrt73@gmail.com, or also Matto @teamcheryl TEAMSCHIERL.com is probably the best way to reach me.
Awesome. I so appreciate it, Matt. You've definitely realized our goal of helping is educating and empowering individuals to take charge of their own health. And one piece of that, and a big piece of that, is financially, that patients need to take care of their own health financially. So they need to be driving their employers also to say, you know what? I've heard of better ways that we can do this. And because some employers, if we put consumers in charge again, that's one of the ways to fix the system.
Right. Yeah. And thank you, Sean, for what you're doing. I think it takes all of us to get the word out, and education's a lot of it. There's a phrase, right? Doctors learn in school very early. I'm not an MD. I've got half a PhD, but right, they learn this phrase, do no harm. And right, do no harm means to the whole person. And so even if you treat the person okay and well, if you bankrupt that person, you're doing harm. So we need to look at this from
I agree. I agree. And I will say that I think some doctors don't want to admit that, but it's just true. I had a doctor on our podcast that said, actually, it was not a doctor. He was going to be a doctor. His parents are doctors, but he decided to kind of, educate doctors about getting out of the system.
Right.
And he said this, it's like, doctors do have a choice. And, if the doctor doesn't know the price of something that he's sending you to, whether it be an MRI or whether it be a surgery, you need to go somewhere else.
Right.
And I totally agree with that. Doctors need to know pricing. And if they don't, they should be the drivers of healthcare, including the financial part. And they need to know about it. So it's important consumers know that they can ask their doctor that. And if they can't, then they probably need to find a new doctor.
They need to take ownership in that. And right, if you're in a hospital setting, typically what the nurses will say is, I don't deal with that. What they're really saying is, I know a lot about that and I'm hassled daily about it, or asked daily about it. It's fair to ask what the cost is, by the way. That's not hassle. But they've written that part off because they know it's a sore spot. I had an incident a year and a half ago, and I was there about 20 hours, and right, just as an example, and I tried to crawl out of there the night before in the ER, right, I'm realizing what's happening, and I knew I was okay, but I'm trying to get out. I couldn't. I was too nauseated. But the next day I talked with a physical therapist for 5 minutes, and he was very anxious to get me set up for appointments, and I didn't, because I know one that's better and affordable and was actually free with my plan. Yep. So I wasn't interested in the scheduling, but he talked to me 5 minutes. Guess how much my bill was for physical therapy in the ER? $384.
I was going to guess $300.
$384 for a discussion to say, I don't want your services. Thank you for stopping up to my room. I was polite, but I don't want to schedule. That was $384. And when I questioned it, the billing, they were more annoyed that I was even asking, like, how dare I?
It's unreal. I mean,
so yeah, right. I mean, on and on, right? But I mean, we all, when I give presentations to our associates, I'll have 30 people, small groups. I'll have 6 people in line. I just did a couple months ago, 6 people in line. One person said, I was in the ER, I had $68,000. Another person said, Matt, I was $6,500 and I'm not even diagnosed yet. What do? I can't afford any of this, and so forth. So yeah, I mean, the stories are endless, but the more
we wouldn't tolerate that in any other industry. A good example is hotels. And I've got a great video on what if hotels build like hospitals.
I saw that.
Yeah, and we wouldn't tolerate it. And I've got a good example. I was in Boulder, Colorado a few weeks ago, and I paid for their internet service, which I mean, it's kind of crappy that hotels will charge for that. Sometimes they get away with it. That's why they do it, right?
Right.
So when I find out that my phone service was better and faster than their hotel Wi-Fi, and I paid for the advanced Wi-Fi supposedly, I just went down to the front desk and I complained. Right, that's what we would do with anything else. Right. And they said, "Oh, well, you know what? I'll just take those charges off your bill, because it was a daily fee."
Right.
Yeah. You complained about the physical therapy charge, and they're like, "No, that's just the way it works."
It was inappropriate to complain, and the
the
biggest difference, right, in a hotel, what happens? You go somewhere else, they know that.
Exactly.
The way that hospital systems are now, it's, do you want this lane to this system or this lane to this system? And without interventions like we're doing, there's no other choice.
Yep.
So as Marshall Allen says in his book, the consumer is not the patient, it's the insurance company. So they're catering to where the money's flowing from. And so you have no power as a patient, as a consumer, as a payer. They don't care.
Right.
So unfortunately, but we can fix that, can't we?
That's right. Consumers need to be in charge of it. And like you talking about free market. I mean, when consumers are in charge, prices will go down, quality goes up, and service goes up, period. And in the traditional healthcare system, none of those things are good.
Yeah, it's amazing how that can work when it's opened up.
Absolutely. Well, thank you, Matt, so much for being on. I totally appreciate it. And we'll have you on to discuss that story on diabetes again and to talk about your book.
Great as always, Sean. Appreciate it.
All right. Well, tune in Monday, 12:30 to 1:30, as always, Health Solutions with Sean and Janet Needham will be streaming live 12:30 to 1:30 Pacific Standard Time right here on my personal Facebook page and the Moses Lake Professional Pharmacies Facebook page and the Moses Lake Professional Pharmacies YouTube site. So you can catch us on those platforms. Also, check us out on the podcast forums because we're available on most all the podcast forums. So check us out there. And I thank you for tuning in and listening today. Thank you so much.